So let's talk reishi. Reishi is a natural mushroom, completely legal, does not cause any type of alteration in your thoughts. And reishi is an anti-inflammatory. It's really, really great for symptoms of anxiety. If you also have high blood pressure, reishi is something really, really good that helps with blood pressure. We recommend this for people who are really needing to have additional focus. If you have sleep issues, anxiety issues, or blood pressure issues, check out reishi.
Welcome back to Rethink with Revitalists. I'm Adam Marr, and today we're sitting down with Katie Walker and Michelle Wiener, two ketamine providers and expert providers. And we're going to hear from the experts today. Michelle, tell us a little bit about yourself and your expertise within the field.
So I'm an integrative pain management physician. My primary specialty is actually physical medicine and rehabilitation. A lot of people don't know about that specialty. And I really learned a lot about traumatic spinal cord injury, traumatic brain injury, and a lot of chronic pain. And then I went on to interventional pain and started realizing that our patriarchal Western medical system is really based on pills and procedures. And so I started to realize I couldn't treat chronic pain unless I established a connection with the patient. And a lot of the patients were really disconnected from themselves. And so I founded Neuropain Health, and we're a multidisciplinary team. We have a psychiatric nurse practitioner, we have great coaches and nurses, and we really allow for the patient to feel safe so that we can allow them to surrender into these experiences so they get to know themselves a little better and start to be a little more curious about their story, how they got to where they are and how we can help them move forward. So ketamine's a big part of my practice, but we also have many different therapies that we add to that.
So did you always know that this was going to kind of be your path? And I mean, it sounds like there were some frustrations with like the system and what was not being able to be provided to the patient. So it kind of took a turn to this, pain management and the applications of ketamine. But like, was this always your trajectory, or how did you kind of like land on this path?
So actually, personally, I had a very close relationship with my grandma. And not to get emotional. Yeah, and she really suffered from chronic pain, and she was isolated because her husband, my grandpa, had died many, many years ago. And she had multiple compression fractures, osteoporosis, and really had a lot of chronic pain. But whenever I was with her, she wouldn't have any pain. And I was so curious about how she would always tell me, just you being here with me takes away my pain. It allows me to feel love. And it was like this, I was thinking, how can I have more love, and how can we add more love to our patients' experience, or how can we evaluate what's missing from their entire life? It's not just the physical body, but actually the psychosocial aspects that attribute to developing chronic pain. So when I was a pain doctor, I realized I was very disconnected from that concept of adding more love to people's lives just by doing things that were more for acute pain. And I was really treating chronic pain. So I had to change to have a more holistic approach to treating patients and understanding really how they got to be in the situation. And a lot of it was their mindset and like the predictive processing from how they were raised to their beliefs. So, I knew I needed more tools in my toolbox. Like it wasn't just about injections and medications. And even though ketamine's a great medication, it's always done in the context of other therapies.
Right. What do you think about the you are my medicine, like that love and close proximity and relationship to you? Because I think like maybe there's a time, where you're like, oh, that's so cute and endearing and loving, but then there is like something about like the energetic presence of somebody else being to alleviate like something within your physiology.
Yeah, like I think like the whole concept of attunement and understanding the nervous system, like we're able to attune to each other's nervous system. But I also think neuroscience has just showed us that love can blunt the response of pain, increasing dopamine, oxytocin. Like there's actual neurobiological mechanisms for why one can feel like their heart is being opened and like actually suppressing pain. But more so to understand that pain is really very subjective and is an unpleasant emotional or sensory experience. It's actually an experience of pain. It's not just how we process signals in our body. So when you understand like it's the processing of pain or it's the experience of pain, then we can help people have more of a capacity to hold pain, because you're always going to have some type of pain in your life. It's not going to be like always pleasurable, but in order to move through it and not really get stuck, you have to have resilience, and you have to have support, and you have to have the ability to hold pain.
Well, pain is something, it's interesting, and I want to dive into it like a little bit more. But we've all connected before, like once, like on email. I think we've had a few calls, but this is cool because like we're getting to sit together and have this, you know, conversation in person. But you guys have known each other for, how did you guys meet, and what's the connection other than being experts in the field of ketamine providing?
Well, I have all greatness comes together.
I respect you so much. Yeah, I mean, she's just a badass, and she's an entrepreneur, and she has been doing this for a long time, and I think we both try to figure out how to help patients the best we can with the system that we're working in, and that's what I always was impressed with you, like trying to go to the VA or trying to help people. We both take insurance, or you know, things like that. We're trying to do it in the right way, where we're not just kind of being taught how to do it. And I think that I've always seen you question things, and I think we have a similar concept of how really inflammation creates such change in the nervous system that leads to mental health and chronic pain. So, and how we respond to stress, and how trauma and stress can really, you know, affect so much of how we interpret signals in our body, or how our brain is on high alert all the time. So I think we've met at multiple conferences, we've spoken together, but it's nice to have another female entrepreneur who is outspoken.
And that's probably, we're very similar to that level. And I don't know if there is anybody else in the space that's like us, you know? I mean, really, like being a practitioner and also running the business. And the reason I admire Michelle so much, like there's so many different levels, but she's also a pain physician. Right. And think about like the whole opioid crisis that we just went through.
Right.
And pain physicians became, right, like the worst people in society, even though they were the specialists. And we were trained, right? I remember when I was in nursing school, I remember where I was sitting. And there was, we went through, you know, we were talking about like, I think it was dilaudid morphine something. And it was like 2003 or 4. And in this book, right, it told us. It was a 0.001% chance that you're going to become addicted to an opiate, right? So we were trained, you were trained, you have to treat pain, right? So that's what we did. That's what we were told. That's what the science told us to do. And then Medicare came out and said, pain's the 5th vital sign.
Right.
Remember that?
Right.
And then, so if people...
Where did that come out in?
Medicare. Okay. Medicare came out, JACO, Joint Commission, all those guys, right? They all run together. And they're the big boys, right? They're the big boys of the nation that could pull the rug out from me and Michelle anytime. But yeah, pain became the 5th vital sign. And when they would give you the, what's the survey?
The pain scale?
Yeah.
Press 80 survey?
There's like the VAS or the NRS. It's a 1 to 10 scale that basically tells you, like, subjectively, what's your pain from 1 to 10.
Right.
If you didn't have a pain score of 0 on discharge from the hospital got reimbursed less. So, you know, so we're doing all these things where we are these healers, right? But now everybody hates Western medicine, you know, and I get it. Like I get it. Like we're very stuck sometimes. We're very compartmentalized. But I think, you know,
so the hospitals are being fiscally incentivized for there to be no pain.
That's right.
But also think about it like this, what actually ended up happening when pain became a vital sign. You had to document what their pain was, and then there was mild, moderate, or severe. So you had to treat the patient once their pain was either 1 to 3, 3 to 6, or 7 to 10, which means, you know, first you start off with Tylenol, then you start off for moderate pain with an oral opioid, and then IV opioid. So you're basically giving patients medication because you're treating their subjective pain score.
Right.
Which basically created the opioid epidemic, because you're sending patients home now with opioids because they had moderate pain because the hospital wanted you to treat their pain, when really we have other tools and techniques that we could have used. 80% of the world's opioids are taken in the United States, which shows that it's very much a cultural influence.
Well, it's absolutely crazy. It's saying you have pain, so we're gonna get you addicted to heroin.
Mm-hmm. Yeah.
Like what?
Right.
Yeah.
And like as human beings, like we experience pain in all sorts of different forms. There's psychological pain and trauma. There's physical pain and trauma. And like you go back, like was it always like the purpose is elimination of pain? Like I don't think so.
No,
you can't fully eliminate pain. And should you live in a life in existence?
What they were trying to say, though, I think back then is like if you were at a level of pain, then that level of pain would increase your risk of your cardiac instability, right? You'd have a higher chance of having a heart attack, different things like that. But yeah, but it was more so like we would get in trouble if we didn't do what they were telling us to do because that's what the system told us to do at that time. So it's kind of crazy, right?
Yeah.
But you're exposing someone to a medicine that they actually don't really need.
Right.
And it's based on a system. So I think what ended up happening was then people thought that you had to get ahead of the pain. So now you have to take the pain medication before the pain comes. And that's really how people got dependent on medication.
They were just doing that like 7 years ago.
Yeah.
Like they were giving people Oxycontin and pre-op before they would go to surgery. And I'm like, okay, we all know Oxycontin probably is not the best drug of choice, and people are coding in pre-op before they go to surgery because they're giving Oxycontin to like an 89-year-old having a total hip. I'm like, I really don't think we should. No, these are the recommendations now. I'm like, okay,
And now the problem that we're having is people are on chronic opioids,
right,
who have pain, and all of a sudden we're starting to get very aggressive about trying to take them off, which is causing them to go to the streets and buy opioids that have fentanyl and then overdose.
Yeah.
Or they're making changes now where you can only prescribe a 3-day supply of opioids for acute pain. But there's so many people that got used to taking opioids on a daily basis that now they're like, well, what's the next option? What else can I do to treat my pain?
I have a dear friend that he's a double amputee. So he had, I don't even remember how many surgeries he's had. And so all the medications and pain medications that he was on. And then he developed that dependency and addiction to it. And then what he told me was like, you go through the pills and then like you're still hurting and craving that and have that dependency now. And it's embarrassing to go back to the doctor. And so it's easier to go and cheaper to have this heroin habit than to be able to. And like there's too many stories like that from within our community. And actually, like one of the main reasons my brother and I, when we got out, started the nonprofit that we did. Well, we'd already started the nonprofit, but we were also trying to do like some for-profit ventures and stuff like that. And we had somebody that we went to high school with that had went into the military. His name was Brad Payne. And he had a similar story to my double amputee buddy. And he died. He succumbed to this because he had that addiction. And I distinctly remember, for my brother, it was like, not one more life, like not one more on my watch. Like, I don't care about the for-profit venture anymore. And it also sounds kind of like, to a degree, like your dissatisfaction with the system also. I'd be interested here, like what was the catalyst moment or like the change in trajectory where you were like, I'm going to be about this in a different way, in a different path?
Well, it actually started when cannabis became legal in Florida. So when
was that?
In 2016.
Okay.
So that gave me another option to offer patients who were dependent on opioids. Had I not had cannabis, I wouldn't have known what else to offer them because it seemed like I needed to give them something on a daily basis to help reduce their opioids. So that was actually my first research, is looking at the opioid substitution when we add cannabis. And then not only were they reducing their opioids, they were sleeping better, their mood improved. And I'm like, okay, I never learned about this in med school. This is a plant and it's used as a medicine for many different reasons. I learned about the endocannabinoid system, and I'm like, what else did I not learn in med school that I can use for my patients right now? Cannabinoid system.
Cannabinoid. That's
it's kind of like a song.
But it's the receptors in the body for that.
Well, it's not just the receptors, but we also make naturally occurring cannabinoids like the THC molecule, which basically keeps all of our neurotransmitters in balance. So when I learned we have endogenous cannabinoids, similar to like we have endogenous opioids, which are endorphins, and I realized that we can modulate many different systems based on the endocannabinoid system. So then it's more teaching patients how to use cannabis personally and personalizing that for whatever specific condition they have and based on their tolerance to THC.
So what would like an example of that be for maybe somebody?
So like, let's say, for example, someone's on 4 Percocet a day and Ambien or something like that. I'll generally ask them, what's your experience with cannabis? Understand their like overall anxiety level about it. I usually start them off with some indica edibles in the evening to decrease their Ambien, or I'll use maybe like a 1-to-1 CBD THC hybrid tincture to substitute for their Percocet. And it's really like trying to figure out how little THC they need, how much CBD to counteract some of the psychoactive effects, and then how well they feel with that, and then reducing their opioids over time. So it becomes their new medicine, which then again, you know, sometimes it's a crutch and they're just kind of using it. But over time, they start to become empowered. They're taking their own health in their own hands. And I like the fact that they're able to use their medicine in many different ways. And I establish a relationship with them. So in the process of using cannabis, I was able to connect with them, because then they, you know, they feel like, okay, if I'm going to talk to you about marijuana, then I could pretty much, you know, open up about my story. And then I would understand, okay, I'm not just treating back pain anymore. I'm like treating the multiple traumas that have happened prior to you having back pain, or I'm treating the limited belief that you have that you're stuck in this body and there's no other hope, you know. So there was much more that was uncovered when I was able to have these conversations with them, because they realized I wasn't judging them, and I was really just offering them a plant and just walking them through how to optimize their life by using it.
So this is so different than like the conventional general practitioner, an hour in the waiting room, you know, maybe 5 to 15 minutes in like a consultation room that's completely, you know, sterile, then off to like your pharmaceutical, go take this medicine. I feel bad. I take this. I feel better. I still keep doing the same things in my life and just expect you know, different results, as opposed to now it sounds like you're entering into partnership, you know, with them, really creating this space and container. Also hearing about like, you know, these themes and expressions, you know, from your grandmother of like how you can have like, you know, loving care for this individual while taking them off something that's damaging them and providing like new alternative pathways. So how do you like bring that love like into the equation, like in this, you know, and kind of navigating this, you know, because you're giving more time to these individuals, right? And like that's hard because the model's not optimized for that. The businesses aren't optimized. Insurance not optimized. So you guys have to be and are really pioneers and leaders in doing something like in a way that's like a near bridge, right? It's a near peer of like Western medicine, but you're extending that, you're bringing it something new, you're bringing different ways of interacting and having that time, you know, with the patient and individual as you're expanding their understanding, not just take this, get better, do this. It's no.
But I think it's the conversation topics too. Like it's not as lengthening of time though, right? So if Michelle's coming in to talk to somebody and she's talking to them on the basis of looking at it as love, instead of coming in looking on the basis of a boss versus employee or vital signs or what did my LPN want to tell me, right? Then it's like you can still make that very succinct information and time effective. But I think too what Michelle just described, and I'm very, very big on this, and then I don't know if something will happen with it or not, but like decriminalization. That's great. I'm all about decriminalization of everything, whatever. But I am not about people dosing themselves who don't know the dose and the frequency and everything else, right? So they need people like us in the space and to where we say, okay, like this is what you should be taking and do it in this frequency. And then let's measure this to see this, right? But when they decriminalize things, they're only giving access to people to take the substances themselves.
Right.
And these people don't have the pharmacologic skill sets that we have that can help them to kind of stay in that therapeutic zone. And that's what I was talking to Adam about last night. It's like, you know, in Western medicine, we don't treat people until they're like partially dead or close to death. Then we think it's okay to treat them because they're ill. And then in the psychedelic community space, they're like, oh, it's natural. Everybody can do it every day. And it's like, no, there's a low and a high, and let's keep you in the therapeutic range. So it's like if there's a way that we can decriminalize these things, but then you put some type of practitioners in it to where it's like, okay, start with this dose, and to where we can actually prescribe with them without feeling like our license is on the line. Like that's a big piece that's missing.
I mean, education is what you're talking about, like actually sitting down. Like I go through the endocannabinoid system, same thing like I go through even with ketamine, why this mechanism will work for you, even though you've tried multiple antidepressants. The same thing with cannabis. Like you have to educate them how to take the medication, what you potentially could feel. It's really just also, just giving them like a little bit of extra support in the beginning so that they're willing to go to this next step because they are very used to take a pill to fix something that's wrong in my body, as opposed to the beauty of cannabis that I realize is it can alter your consciousness and it is considered a psychedelic.
Right.
It can be used as that.
Yep.
So when they would have these experiences over time, and one of my research studies was just using cannabis for chronic pain seniors and just showing the reduction of pain from that population. So a lot of my patients are older and they just want to get off their medications and they are hesitant to start cannabis, but they know there's no other option.
Yeah.
And then another medicine will just cause a side effect, which they need another medication. So teaching them how to do it in a way that they're not scared and that, you'll be able to support them. But then when they were having these alterations in their consciousness, which does happen with cannabis, it also opened a whole new life for me where I started to realize this, like love, awe is also a beautiful medicine, and being able to kind of step back and see something from a different perspective or just kind of slow down a little bit and just change the lens. Cannabis showed me that. And then I realized, and then, Julia, my good friend and coach, she was more interested in psychedelics at the time. And she was like, you were trained in ketamine. Why don't you just start using ketamine? And I was like, it's for pain. It's an anesthetic, So then I had to properly get trained in ketamine-assisted therapy to understand how I could use ketamine to treat the whole person.
Wow. I have a lot of veteran buddies and some that are business leaders, family men. They're on the forefront of the advocacy on cannabis and psychedelics. And one individual, Gary Hess, he's based in Louisiana. He was a Marine that saw like the absolute worst of it, and cannabis was instrumental in helping him to start to process and cope. And he was an out front advocate in Louisiana on the national level, being able to share, couple with, the research and the science, but what you're saying to help kind of shape this narrative. And I think, I think that's what like my community and other individuals like who are finding ways to heal with these things are doing and should be able to do. But then the other side of that, and something that you said, kind of talking about this older population that comes in, to your clinics, and it's really cool listening to you both and how you your clinics are the expression of you and kind of how you're framing this problem and solving for it. And you're very much from like a pain, right? And so I'm a human being. I experience pain in some capacity. So I'm going to come in and see you. Like, how are you like grabbing them? Like, what are the type of pains that people are coming in with? Sounds like some older folks, but I imagine it's, pretty diverse, kind of spread. And how does ketamine really help with the pain management side of things? So
there's different types of pain. Like there's different types of depression. There's pain that's inflammatory. That's pain that's what we call nociceptive, which is affecting actual tissue in the body. There's pain that's neuropathic, like people have peripheral neuropathy or trigeminal neuralgia. And then there's this whole section called nociplastic pain or neuroplastic pain, which is when pain has been in the body for at least 3 months, that it's now in the central nervous system. And we get this hypersensitivity to all signals. So a lot of times someone has fibromyalgia, for example, or they'll have peripheral neuropathy, and it's just something that has been going on for a long period of time. And the fact that it's been chronic is now also affecting their identity.
Right.
And now they're very much attached to, I am my pain. Like they'll say, my fibromyalgia, as if it's like an entity, right? Like separate than themselves. Yeah. So the fact that they now identify with their pain also affects their default mode, right? They're very much stuck in thinking about their pain, or they're thinking about what they can't do because of their pain. And so all of these things are limiting their function. and then it's creating just a different person. And so for the most part, I don't say what type of pain I use ketamine for. I would say it has to be chronic, I would say, in nature, but it's more of a centralized pain. Yeah. And so there's many different conditions, but really I'm treating the person. And the only way to treat them is to do a proper assessment, which we call a biopsychosocial assessment.
Okay. So then is the ketamine allowing the individual to decouple from like those thoughts and the personification of the pain that they're experiencing and managing?
Yeah.
So now they're perceiving and dealing it within a different way, which we know that if you can actually do that, then you're probably releasing some of that pain that you've been carrying because it's much as psychological weight.
Well, it definitely breaks the pain cycle.
Okay.
And it's an anesthetic. So during the time that they're using ketamine, they probably are not experiencing pain, but they're also, decreasing the activity in the default mode, allowing connection from other parts of the brain just to give them a different perspective. So in breaking the pain cycle, they're also viewing themselves from a different perspective, or they're just able to understand, just to kind of take a break, like a lot of times they're just so focused on their pain and their body, and they're able to understand that maybe there's another option for them, or maybe there could be a different opportunity. But the most important thing is really to allow them a container to feel safe so that they can let go of some of these beliefs, because a lot of them have a lot of shame. I've been living with chronic pain for a long time. That's affected my family. I can't work.
Right.
I'm not physically active. So there's shame, or there's fear. Fear is exacerbating the signals of pain in the body. And a lot of times that emotion is coupled. So patients will say, the only thing that helps decrease my pain is an anti-anxiety medicine, for example, like where you understand that fear is a big component of that, and calming the nervous system allows them to interpret what's actually happening in the body accurately. So we do something called pain reprocessing therapy with or without ketamine. Either way, it's just trying to reprocess signals and then give them a protocol how to move forward and kind of like change their patterns and habits, incorporating all lifestyles.
It's the other day I was thinking about it. It's complex trauma.
Yeah,
pain is.
Yeah.
So there's like PTSD, and there's a little tiny C with PTSD.
Yeah,
and it's the same thing, right? So when people get in pain, they get into a state of being out of control. They don't know when it's going to stop. And so when they get that recurring cycle, like, we should diagnose people with chronic pain with complex PTSD, because it's sending all these defense mechanisms and it's making everything worse.
Yeah, because like even if it's just being like so simplistic, like what is pain? Is like me acknowledging that I'm existing in an undesirable state because of some.
It's actually just an unpleasant experience. That's really what it is.
Yeah.
It can just be sensory. It doesn't actually have to have physical tissue damage. That's actually the definition of pain. So when people are educated properly and they understand that pain is not just in the physical body, but it's literally just an unpleasant sensation.
Right.
That's what pain is. Then it's, can you hold this pain? Do you have the capacity to kind of move through this pain?
Tolerance?
What's your pain? How can we improve that?
But every time you take opiates, right, it turns off your natural pain system. So what we're doing in society right now with the opioid crisis, where we're turning, decreasing all these people's pain, they've been on pain medicine forever.
Right.
We're torturing them because they feel pain worse being on opiates than they would if they weren't on opiates. And then we're mandated to start taking them off of all these things, right? And you're not giving them access. And literally these people, like, you could touch them and they will feel that pain down their leg. Their skin will be on fire.
And that's what you call opioid-induced hyperalgesia. Taking opioids chronically makes you more sensitive to pain. So we're giving people opioids to treat their pain, then putting them in a state where they can't calm their pain signals down. So they're more sensitive to it. And then we think of them like, as if they're hysterical, or they're overreacting.
Yeah, you're already on pain medicine. What more do you want?
And it's really because they're not making their own endorphins. So they can't, so then they say, I don't feel any joy, right? I can't, the things I used to do don't give me any pleasure anymore, because they don't have their natural endorphins.
Yeah.
They're not able to feel content. And it's really because the medications are blunting that. And then they become kind of hypersensitive to everything because it's living in the central nervous system. So then they have insomnia, dizziness, nausea, all of the, like, ringing in their ears. I have a guy I'm treating right now. He came to me for for abdominal pain. And I mean, he's been to all these different GI doctors, and it's all based in anxiety. I mean, he's actually getting so much better using ketamine because he just uses it as like a timeout to just kind of feel relaxed and calm his body and change the way but I had to give him so much education to understand this pain is caused from the brain.
Right.
And we need to be working on how you're interpreting what's going on. And usually it's something stressful happened and then I started feeling this pain. It's not like I ate something and then it irritated my stomach, right?
Well, I think that's really beautiful, and I hadn't really thought about it like that. But giving somebody like a time out from like their like current state of being and existence, now you've given them permission to exist like in a different way, and consciousness is maybe a little different, and the things that they were feeling they're kind of detached from, and now it's like, okay, you can exist differently, and how can you maybe move more towards that, like through these practices, understanding, education, everyday things that you have at your disposal to be able to relieve this, these pressures and things that you're experiencing, because you indeed have the capability and capacity to do so, and you just proved it in that session in there.
Well, and I think that with PTSD, my personal opinion, ketamine should be a first-line treatment for PTSD.
Really?
It's amazing. Like, you treat a lot of PTSD guys?
Yeah.
Guys and gals?
And not only that, but like I'll have a patient I'm treating for chronic pain, and the first thing that comes up is an experience they had with their mother, right? And so then it doesn't have to do with their physical body, but it has to do with the trauma that they never really healed from, or it has to do with a relationship that they're having a challenge with. So, there's always some type of trauma, or there's always some type of chronic stress that led to them developing chronic pain. So if you're not really understanding that story and you're just trying to use ketamine for the body, then, other things are going to come up. You have to be able to support them. So there's nobody that I treat who has chronic pain that doesn't have either PTSD, generalized anxiety, or depression.
And one thing with those pieces too, like looking at the chronic pain aspects, I went down a rabbit hole one day. Probably been down a few.
Which rabbit
my
hole?
Time. Which day? This is early morning today. But I was looking at low back surgery, right? Because like low back surgery,
lower back, surgery?
Lower back, yeah.
Okay.
It's one of the most common, most popular surgeries there is, right? They didn't start doing that until like 1990 with lower back surgeries, and we actually have more lower back pain today than we did back in 1990 when they first started doing that. And one thing they've proven is that mental health and pain are directly related, right? Chronic mental health leads to chronic pain leads to chronic mental health. So I was thinking, and I don't know, like antagonizing on this if you like, but, I was thinking about stress, right? It's like, where do you hold your stress? You hold your stress. A lot of people hold it in their hips.
Yeah.
Other people hold it in their shoulders.
Sure.
And you've got a big old, you got your brachial plexus up here, right? It's all these little nerve endings. And so then I was like, probably two of the most common surgeries that are out there that we do is neck and lower back surgery. Yeah. And a lot of times, as Michelle said, if they're properly educated, what we do in the OR? Oh, are you hurting? Okay, let's take you in. Let's open it up. Let's see what's going on.
Mm-hmm.
Yeah.
Everything's fine. Everything's fine. Like, we've had people that they've opened up like 12, 20 times over like 20 years. And they're like, every time we go in, it's fine. And it's like, guys, like, just because the anatomy doesn't show anything different, like they need to see something. And that's the piece that I think that, Michelle and I and Julia, when we heard that we're trying to do is like the Western medicine space is compartmentalized. It wants to replace a part.
Yep.
They don't see that the entire body is connected.
Yeah.
So you've got to look at the entire computer system. You can't just go in and cut the wires here and cut the wires here. I'm just going to replace these wires right here and expect everything's going to work fine. No, things are still going to short out. It's like, how do you start at the beginning and you help the whole system change to the end?
But also, it's a great point because you have to understand why we do more back and neck surgeries than before. And that's because we basically treat MRIs, right? Mm-hmm. Someone comes in with back pain, you order an MRI for them. 80%, I think it's 80% of people over 50 have disc degeneration on a lumbar MRI, and 60% have a disc bulge, right? But that still may not be the source of your pain. Yeah. But if you do say you have pain, you get an MRI, you see some findings, then now you have that diagnosis. So now that's part of your identity. and now a doctor has to treat it outside of you,
right.
which means an injection or a pill. And then you go through this pain management world where nobody's focused on just lifestyle habits, like what's your sleep like, and what are you eating, and are you moving your body?
I mean, you guys just like hit the nail on the head for me. Like I have a disc problem on my L5, and I just went and had the MRI done and had a look at it. I swear. And he's like, he was basically like, first we did the X-ray, and he's like, oh, you have degenerative on the L5, and it's just wear and tear, older, compression. Apparently jumping out of airplanes, landing on the ground it's not good for you. Miles and miles of
details.
Rucksacks, thousands of, flight hours. These things are not good for the spine over time. And so just kind of chalk it up to wear and tear. But like for the last 9 months, like my back has been in a degraded state of like being able to operate normally. And so it's like, there's got to be like more there. And I have all this knowledge, like for the most part. I'm not saying I know everything, but I'm saying like, the connection between all these things, like I know it, but I'm still trying to assess like what is the physical ailment that I'm experiencing. I might also like search up and go down a rabbit hole of like, what is the spiritual energy behind this energy and things like that, and how can I envision and focus my awareness on like a fully healed disc. Like, can't regenerate your disc. I was like, oh, just wait and see, doc. But maybe I can't. And what the MRI revealed was that I guess like the disc is like a semi-permeable like membrane, or it has, and the wear and tear can get so that like spinal fluid was accumulating and like through that, and so there was like a cyst of spinal fluid in the disc, and he's like, hey, we can't do anything for it. And it's like, so this is your medical condition and you'll have this. And I was like, okay, I understand that physiologically that's what you're telling me, but I also don't accept that. Mm-hmm. And I'm going to manage it like the best I can and like continue forward, still thinking like, what are the ways in which, I can be, as active as I need to be for as long as I can, while managing this and not letting it define me as like who I am. And I am this like thing. And oh, by the way, he's also like, but maybe like stem cells would work. And so like I'm 100% like going to go to Colombia and get like a baller stem cell treatment.
But what have you tried? Like what else have you tried? Like the whole point is to.
Well, nothing. Tell me what should I try?
Yeah, physical therapy. Yeah. There's an International Physical Therapy Association. I love reading about them. Yeah. They are so anti-opioids, anti-surgery. Like it's really a cool angle. They talk about like you build your butt, build your glutes. And that if you have like people who have like more of a bubble butt, they actually have decreased back because you're helping to support all those additional structures.
That could be it. I mean, I've fasted to reduce like inflammation. I did a 21-day fast in July of this year. I mean, I don't do like twisting and moving and bending like exercises and weights anymore. Like I put like a calisthenics like program in that focus more on the core. So it's like those are low hanging fruit things that I can do.
And most of the things that you should do are things that you have control over,
right?
Because you'll always be able to have control over that. So it's really giving you the tools to then say, what's like, we call it like a pain recipe, which basically means what's going to set you up for the most amount of pain and what's going to make your pain the least most like to affect your life. Right. So if you're not sleeping well, if you stop being physically active, if you're, or you even figure out what caused more pain today? Was it because I was more stressed? And then understanding that allows you to really understand what's the root, because you may have that L5 disc, but it really may not be the source of your pain if you track it properly. The other thing is physical therapy is great, but the physical therapists don't do as much movement and somatic work, and they really don't incorporate emotions behind the pain. And so a lot of what I'm doing is actually more somatic or just getting people to move their body in different ways because they're so rigid and they're stuck in these patterns where they won't go certain places because they think it's going to hurt. And we take them to those places with support to try to help with alignment, posture, and core stabilization.
Yeah. And I mean, I think just like acknowledging that there's like a buffet of things out there that can help, and what I need to do and what everybody needs to do in their life is not put that burden on somebody else, and get to the point where like the knowledge is somewhat inherent and you can be a continuous learner. Like you actually have to be. And but in doing so, you can develop like a practice that's right for you. And if you're experiencing a certain amount of pain and you don't know like really where to start, like a pain clinic like yours that, you know, uses, you know, ketamine or Revitalist would be a great entry point and start. And then it's like, what are the things? And so I know like that when I wake up in the morning, the first thing that I need to do is I need to go and have this time of like meditative, like prayer, while I'm still in this kind of dream state where I set my loving intention and gratitude to exist in that plane, like for the day. And then I'll go and take care of some family stuff. And then I'll go like sauna and work out and do some like reading for my soul, as opposed to being like reactively driven by my phone and emails and those kind of things. So this was like, you know, a practice that I needed to be able to be successful, to do the focus driven work that I needed to do. And that might be right for somebody out there, or there's a unique practice and protocol to optimize your physical well-being, physical, mental, emotional, spiritual, so that you can take on the activities of the day. And I think what I hear from you both is like you're taking like the best of Western with these powerful compounds for an individualized practice and approach for that person, and partnering with them like through their journey. And I think the last thing I'll say on this is, especially post FDA decision on MDMA, one of the things that I'm really looking at, and Katie's really helped me with this too, and this conversation is so illuminating on the aspects of like ketamine for pain management, but just how broad the applications of ketamine therapy can be. The fact that it's like legal and available right here, right now, and that my understanding is like veterans, you know, can get it like through the VA. And I think that the community should be looking to leaders like you guys, because you are on the forefront of that. And this is the space where you can legally build the infrastructure right now. And I'm excited to see what happens in this space in the next 2 to 3 years, while other compounds are trying to figure out how to fit into the system.
And I think a big piece of that, right, is like if you do have pain, right, ketamine clinics are a very good option to look into. Right now, the most accepted traditional option for people that have pain is they'll have pain, they'll do the MRI, they'll get surgery, they get on opiates, they get something like central sensitization syndrome, to where like everything starts hurting and they're not sure why, but anatomically, like everything looks okay. So then their primary care feels uncomfortable, giving them more opiates. They send them to a pain clinic. There's a lot of pain clinics out there that do not look at the patient's psychological wellness. They're very traumatizing. They're very belittling to people. You know, they will make you, right? It's like, Adam, I gave you 30 pills. Let's do your count. You know, so you're getting your count out. You're doing your drug test with the door open, right? So you become like cattle almost.
Yeah.
And some pain clinics, and some state statutes, right? So it may not be just the pain clinic. It's the state statutes that are telling these physicians and what they have to be doing, right? And it's a very, very damning system right now. So if people do have pain, you know, like I said, I would search out ketamine first, because we're not treating your pain. We're treating your central mediator that's producing these negative symptoms, right? And there's a really, really big difference. But I mean, I've had people kill themselves that go to pain clinics because those providers make them feel like such bad people.
And
terrible.
The pharmacies.
And the pharmacies.
When they go to pick up their meds, they feel judged. You know, they feel like they're, and it's really, they're a product of the system that we've provided them, which is not sufficient. And now we have other tools. We just need insurance to start covering it so that we can properly offer it to everyone.
You need insurance to start covering it. And then also, I didn't tell you this. This is funny. It's a funny story. I get a letter from state of Tennessee in February, March this year. And it says, you have the word pain on your website. You cannot say the word pain unless you're a licensed pain clinic.
Wow.
So I find the guy, I call him, and we have this whole discussion.
We'll see about that.
Of course he did.
They were like,
so
you got to call him out.
Picking up his kids from school.
Found him. You know, but he was telling me, I was like, well, you know, we go down this whole list. I was like, I can't say pain. He's like, no. I was like, how do I do my assessment? And I was like, do I have to say like boo boo or like hurt? I was like, isn't this like, like the right of like freedom of speech, to say the word pain? And I was like, what about somatic therapies? What about therapists that talk about pain? They use nothing else. They just talk about pain. He's like, nope. I was like, they can even talk about pain. He's like, nope. And I was like, what about acupuncturists little did he know, he's dealing with a psycho, right? And I'm like, what about acupuncturists who are approved through Medicare to do acupuncture for lower back pain? He's like, nope. And I went through, I was like, what about massage? Can massage therapists do a massage for pain? Nope. And in my letter, it stated I was going to be fined $5,000 a day if I didn't take it down, right?
These pain people are for real.
Yeah, so, it's like, dude, come on, and unfortunately, I mean, I have some amazing people like me, it would be somebody like Michelle, I have in the state of Tennessee, and I called him and I was like, this is ridiculous, and unfortunately, right, I'm stubborn enough to be, to find the guy who says the letter, but what about the people who get that? And actually my ex-husband, he's like, I saw your letter. He's like, do not get on your white horse. I was like, this is really a white horse. Oh my God. He's like, do not mess with the health department. And I was like, but I really need to say something. But anyway, I called my friend who sits on the pain management board for the state. And he's like, no, this is not what we mean. They're misinterpreting the data. He's like, I'll take care of it, because it's like, we don't do any type, zero. And unfortunately, I knew the definition of pain clinics when he told me, he's like, you have to be a licensed pain clinic. I'm like, I give 0 opiates. Mm-hmm. You have to give at least 50% opiate prescriptions in the state of Tennessee in order to be deemed a pain clinic. And then, you get licensed as. I was like, I give 0. I'm not even applicable to be licensed to be a pain clinic. He's like, nope, everybody's got to be a pain clinic. Mm-hmm. So it's just, it's stupidity, it's improper education.
The flip side of that is Spravato. In the sense that is the intranasal ketamine that's only approved for treatment-resistant depression or major depressive disorder.
Mm-hmm. And
suicidality. But if I give it to someone who has major depression but also has chronic pain, it could probably help their pain also, or it could probably help decrease their opioid.
They're all connected.
So even though they are seeing me for chronic pain, but they also have depression, perhaps I could use Spravato for their depression and then see how it's helping their physical pain also.
Yeah.
So in speaking about pain, there's certain conditions that are more applicable for ketamine. And yes, chronic pain, but also like fibromyalgia, glossopharyngeal neuralgias. Yeah, that's
fun to say.
Well, complex regional pain syndrome is the biggest one, or RSD.
Complex regional pain, RSD.
Yeah, that's like a hypersympathetic nervous system state that creates chronic pain, which is also interesting. That's the one that you do the stellate ganglion block for. But it's an interesting condition because the cause of it is really a hypersympathetic mediated state, which is very similar to like anxiety or PTSD.
Yeah.
But they have physical manifestations in their extremities because of that. So that, like, the guidelines state that CRPS has moderate evidence for ketamine-assisted therapy, and then all of the other chronic pain conditions, there has to be an associated mental health condition for it to have moderate evidence. Everything else is kind of weak. But for the most part, it's more of like a neuropathic, centrally mediated pain that has gone on for a long time. Fibromyalgia is like a central sensitization state, chronic migraines, IBS, pelvic pain, TMJ. And that's because it's in the brain. It's really like migraines. What's the cause of migraines? Nobody really knows. There's 5 different meds that all potentially could treat it. Same thing with pelvic pain. How many people with pelvic pain had some type of sexual abuse or some type of
see a lot of that
trauma, right? Yeah. And it's like showing up in that part of the body, but you're not going to treat it with just a pain medication. It's a whole process to help that person, again, feel safe to tell their story. Maybe put their defenses down a little bit so that they can approach that in a different way, so they're not really feeling tight and stuck in their body or constricted. And a lot of it is like flexibility in their mind and their body, how they move through this pain, how they view themselves. And a lot of times with trauma, you don't really see the whole picture. You only see a part of it. So sometimes going back and having these ketamine sessions gives them that space to then reprocess what really actually happened.
Yeah. Amputations are good for ketamine.
I have a patient right now that she's and Julia's working with her too. So this patient was basically driving with her wife and her son, and she was stopped at a light. She went to the back of the car to get a blanket for him, and a drunk driver hit her and amputated her leg. So it was a very dirty amputation requiring multiple surgical revisions and infections, and then finally getting her prosthetic limb. But clearly she has post-traumatic stress disorder and depression and phantom limb pain, and she's on opioids for the multiple surgeries she's had. So when you look at someone like that, what are you treating?
Right.
You know, what are you not treating, right?
Yeah.
Yep.
So how can ketamine help? Well, it's helping her.
Interesting.
Comprehensive.
But actually, I'm using Spravato with her because she doesn't have the ability to afford ketamine, and we got it approved through insurance, and she does have major depressive disorder. And what I see is that she's able to focus. She's able to be productive in life. She's able to sleep a little bit better. And most of it is helping her mindset, but it's also helping the capacity to hold pain. So now she doesn't need to take her medications as often, and she's getting a job now, and she's, hopeful. And I think that's a big part of it, is just having hope, having another option.
Well, this is a question for both of you guys. Where do you want to see the industry, go from here? Like, what's in the next 2 years to
insurance coverage
Okay.
for access.
Katie's got this on lock.
Yeah, I was literally about to say insurance coverage. The number one is insurance. Yeah.
How does that happen? How do we get that?
I think we just need longitudinal studies showing how.
We just need to show up and just talk to them.
No, but
we do. Yeah.
Unfortunately, we need the evidence to show how post 1 year they still have less pain or less depression or are on less medication. So I think it's having those longitudinal studies.
Are there studies like that going on right now, or studies that you guys are?
I do have the smart guys.
Yeah,
the Solomon guys. They're doing
the smart guys.
They're doing the data, retrospective data publications, and they're looking at the pain piece, so that might help.
And then where does that argument get presented? Peer-reviewed journals,
and then you present that to Medicare, and then you show how we can decrease opioids
at the federal level.
First state and then federal.
Yeah. And one thing I got to tell you about this one. Here's another soapbox. I love adolescents with ketamine. I think they do amazing too. They're so plastic, and it's like they're so smart. They have no idea what to do with themselves. And here we are telling them advice that we think's good, and they just think that we're just old. We don't know what we're talking about. So so ketamine is amazing for them. Kids, something's going on now. I personally think it's a vitamin C deficiency in all of our foods. I think that's why our tendons and ligaments and all those things, our red blood cells, they're not maturing to the level that they need to be. But there's a significant percentage of people that, teenagers, especially females, if they have acute breaks in their wrists or their ankles, their chances of developing CRPS jump tremendously, right? So I have this dad. I didn't win the argument. But I have this dad who called me, 13-year-old. She's done everything. And I was like, she needs to do ketamine. This child, she had a horrible, they're begging people to cut her arm off, right? And I'm like, she needs to do ketamine. He's like, I completely hear it. Let me see what I can get her mom to do. And I had him talked into it, had the little girl talked into it, kind of thing. And they decided on a spinal cord stimulator.
Oh, wow.
And I'm like, it's the spinal cord stimulators, right? Because when you take them in surgery, you do a general anesthetic, they cut the back open, they stick in this, stimulator.
It's a permanent device that you implant in the spine to, it's like a TENS unit. You stop the signals as much. So it's like a big distraction.
And you have to get the batteries changed out once every 2 years, so you're just you're looking at this, right? And you're just seeing trauma. And I'm like, can you please, God, just try something that's least invasive, right? Or a little bit less invasive for the ketamine aspects instead of putting this child to sleep. And that's the other thing that frustrates me from an anesthesia standpoint is we think anesthesia, it's safe. It's 99.9% safe. Yeah, you're right. It is safe. More than likely, you're going to wake up. But what people don't see is repetitive anesthetics decrease your cognitive function, and nobody knows why. And the only reason we know anesthesia so well, it's not because we test the brain, right? That would be unethical.
So we do smart surgery.
Yeah. It's because we test the lungs. So the lungs are a direct path to the brain when the brain's asleep. But nobody looks at these repetitive anesthetics like, oh, it's fine, whatever. No, it's not. And, children who have pediatric heart conditions who have multiple open heart surgeries along the way, they their intellectual ability does not get to the level that it should be. So, here we're seeing ketamine, right? We're seeing growth. We're seeing the brain can grow. The brain can reset. The brain can do all these things. But we're too damn stubborn to think that it's too big of a risk to try on our child when we've been given it for 54 years, to pediatrics, C-sections, like to all your autistic children that have to have blood draws. We've been given ketamine for over 5 decades.
Yeah.
But I think it's the word ketamine really is, it's the stigma behind the word, because it could be a very gentle medicine. You could really use it in the right context, in a very low dose with the right route of administration, and have a very gentle experience. And I think that, like for adolescents, you're not going to really send them to the moon. You're just going to support them in a different way to put them in that dreamlike state that may help them. But people think of ketamine. Imagine to pick a spinal cord stimulator, a permanent implant, over a potential.
I tried so hard. Yeah, I tried so hard to win that one. I didn't win it. But here's the thing: when your child goes and gets a spinal cord stimulator, the percentage that she may be receiving ketamine during her general anesthetic is pretty high.
Right. I have people who come to me who literally say that my pain went away for a day or two after I had surgery, and I think maybe I had ketamine, and that's why they want to try ketamine.
In anesthesia, people are using a lot more ketamine in anesthesia.
So I think one of the things you guys are talking about is like this paradigm shift in the cultural aspect and component of like understanding ketamine, and I think there's maybe like a perception. And there's maybe history and understanding, things that happen with misuse and abuse. And then it's like, oh, well, it's this powerful thing that can induce these, altered states of consciousness, which starts to like lop it into the psychedelic, which can be like, okay, it's something to be feared. But in reality, it's so great to have this conversation today, because you guys are creating such an incredible argument for the therapeutic benefits, across generations. We talked about the elderly, we're talking about the pediatric cases, we're talking about, the military, we're talking about, pain as an undesirable experience that somebody's having, and how that's a root cause for so many other things. And just allowing somebody the opportunity to relax into this and allow these things to start unfolding and unwinding in the body allows them to enter into this new state of being in existence. And it's like, we should have that. We should have access to it. It should be insured. And what are you guys most excited about, for the future? Or like, what's the thing, that you're like working on next, or most excited to be contributing towards?
I love working in a team. Like I have a really great multidisciplinary team. And so I'm always practicing with the team. Like, who's the best coach for this person, and what's the best pacing protocol for them, and what's the best therapeutic option, and what's the best route of administration and dose. And so I love the art of medicine and not just the science. And I think that I love practicing with the group that I have, and they are the medicine a lot of times. They're supporting them in a way. So for me, it's more clinical experience with my team. And I think it's just educating people about understanding what pain really is. And so when they feel that pain can change, they have an option. And so it's just education, really. It's very simple to understand that, like, we know that depression is not a serotonin deficiency, the same way we know that pain is not an opioid deficiency. We are aware of this from the evidence, but it's unfortunate that we need the studies to tell us that. But now that we do know that, and we have neuroimaging to show us what's going on in the brain, then we could help people understand it a little bit better, because they like to see that evidence. So I think it's presenting it to people in a way, and also changing the way that physicians are practicing. Everything that I learned in school, it's not like I use that all now. And most of what I'm actually doing, I learned after my training. So it's also like for doctors, all practitioners, to continue to get educated properly in what's going on these days, because I feel like people are very stuck in what they learned, and that's not working anymore. We need new solutions.
Hey, and can they get CME credits like in this stuff?
Yeah.
And there's all sorts of ways in which you just have to.
But I think it's also for practitioners to find something that they're really passionate about, so that they continue to learn. Otherwise, are you offering some CMEs?
I just got it.
What do you?
I was like, is he teeing me up right here? No, I just got approval for CMEs through ketamine. Ketamine. What is it called?
I don't think I knew that I was teeing that up for you.
The impact of ketamine therapies.
What
But yeah, it's talk about ketamine and how it's helping with mental health, pain, and all those things. But yeah, University of Tennessee's Medical School. I just got that CME approval across the nation.
So that's huge.
People who want to learn about ketamine. Yeah, it is. It is big because it's like the Matthew Perry. We should talk about Matthew Perry.
Yeah,
especially with us sitting here, right?
We should.
About addiction and physiologic addiction compared to psychological addiction, and two, talking about the ethics of a provider. People don't understand that, and Adam and I kind of talked about that a little bit in the psychedelic space. Is a big lack, right, in the psychedelic space, and they are trying to improve it. Is ethical standards, and as you know, in the medical world, we get ethics shoved down our throats throughout our careers, and we're taught basically we sacrifice ourselves for our patients.
Yeah.
Right. Like we are their protectors. They are coming to you. You do everything to protect that person. And, but looking at Matthew Perry's situation, right? Everybody wants to blame ketamine. It's not ketamine. It was the entire situation of him being a vulnerable person, having people that were ethically aligned to protect him, and they abused him financially, neglect, malpractice, all these different pieces, to where at the end of it, he lost his life.
And people he trusted. Right. And it's changed. Even my patients, they're a little bit hesitant, because, and I'm like, how do you not understand the big picture here? This is someone who had significant pain that was using different substances all throughout their life to help treat the underlying cause of some type of pain there. And then, obviously using a tremendous amount of ketamine in a hot tub and drowning is a way that, you're setting someone up for disaster. But to think it's the ketamine, it has nothing to do with really the ketamine. The ketamine potentially just put him over the top there. But clearly this is someone who was in need and was very susceptible to having other people influence him in a very negative way. And it was people who were making money off of, selling ketamine to him, basically. Yeah. The whole situation really, in one sense, it's good that it slows things down, because I think there's too much prescribing of ketamine. And I think the whole at-home ketamine is not that safe often. And so that's not a route that I like to take. So I think in one way, like I know a lot of times during COVID, they were open to the at-home model, but I don't think that it's as effective. Obviously, they're not doing coaching and therapy, but also who knows if they're getting ketamine from other providers. So there has to be some type of some guidelines or something that like how this is not going to happen again. And like we have a system called eForest in Florida. It's a way to check everybody's controlled substances. So shouldn't that have come up on something to understand? But there's no guidelines. Like you could just check that, like for opioids, for example, another provider can't prescribe opioids if you are. So we have like a checks and balances there. There has to be some form of checks and balances. I think that at least good should come out of this, right? But I think ketamine, the word ketamine, got such a bad stigma because of, and it's like, look who you're talking about. It's actually someone who really needed help and was being abused by practitioners.
Yeah, and I would even like elevate it a little bit more into like the more broad like celebrity culture, like Hollywood culture. Like if you're looking to that culture for like the answers, like you should probably also come in for therapy because it's not where you should be looking for answers. And you guys both so eloquently, kind of talks about his past and the challenges, that he faced being a product, of that culture, but also just like being a human being. And, for every, terrible instance like that, there's, thousands, hundreds of thousands of it being done, the right way in helping a person. But because of the notoriety, because of, somebody who was, a friend to all of us that came into our, living rooms, like it spotlights that and it really hits an emotional chord, and it can be absolutely devastating and damaging to so much good. And that can be with anything. It's not just, ketamine. It can all sorts of different things that could follow that same pathway.
And even just understanding dissociation, because I'm sure he was very dissociated at that moment to not even realize where he physically was, not to mention it's an anesthetic, so he doesn't feel his body. So being, to people dissociate because they're dealing with pain or trauma in their everyday life. Now you give someone ketamine and they're having a dissociative experience, they have to be supported, and they have to understand where they are. That space, that container is extremely important.
And it's like you change the word Exchange the word ketamine with alcohol.
Yeah.
Matthew Perry drowned in his tub or in his hot tub because he was drunk with too much alcohol
in his system. Yeah.
Society wouldn't have even given that two thoughts, and they would have went out and bought their 6-pack of beer.
Yeah.
You know?
You're exactly right. And it's the way that we, view and advertise and consume and normalize.
Yep.
And, there's still rules and regulations, and you can be, punished and, go to jail, for use and abuse. But, people are suffering from it chronically. Like I was for a long time. I was a functioning alcoholic, and abuse that way more than I've ever abused, like in anything else or any other drug. And
I have tons of patients who drink alcohol because they have physical pain.
Yeah.
They're just numbing the pain.
That's right.
I mean, it numbs all types of pain.
Yeah.
And then in that numbing is where they no longer know how to understand what's actually happening in their body. Like they just are needing to like completely reset or recalibrate what's actually happening because they've been numbing, so they're really not feeling anymore. Or they're just in their thoughts all the time, so they're not really in their body, properly present in their body.
And one thing about like alcohol, it's like, why is alcohol not a Scheduled I drug? It causes an alteration in thought.
Yeah.
It has zero medical.
There's no medical use.
Because there's too much money.
It's toxin.
It's a toxin. It's a poison.
Causes disease.
Right.
It should be, right?
Yeah.
There's no medical use. It's highly abusive.
Yeah.
Right.
Adam's going to lead that one. We'll be behind you, Adam.
Michelle, well, look, I mean, I've really enjoyed this conversation, especially, the angle, and really looking under the microscope of this from like pain, which I've never really done before. And I think it's so exciting to see how, like you very capable female leaders are stepping up to really kind of usher in a new era of medicine. And it's one that, I personally have been advocating for the last 10 years. And to see your own journeys to like the present to today, and the businesses that you built along the way, and the people and the lives that you're saving. I mean, it's incredibly inspiring. And just want to give you guys that recognition and validation to just say, like, please, like, keep going.
Don't stop.
Don't stop.
That's like the quiet. I mean, I've got the most admirable quiet respect for Michelle because, I mean, we get it, and it's not easy. Not easy, but it's worth it.
Yeah. No, I agree. It's not easy, but we just have that passion. Like we just know there's a better option, and we have to give it to people that are open-minded to it, or we have to educate properly, and we have to keep doing what we're doing because there's other people which are not doing it the right way. And, I think it's important that we all stick together also and really understand there's a different way of doing this that could help people get their entire health back. And there is a possibility for things to change.
Michelle, how do people find you and get a hold of you?
My website, drmichellewiener.com. Same thing, Instagram, LinkedIn, Dr. Michelle Wiener.
Yeah.
She's doing a lot of amazing things. Definitely follow her.
Katie, any final thoughts?
Thank you, Michelle, for coming out and here.
For having me.
No, it's a huge honor. She's an amazing leader. So to have amazing leaders on this show like you and her, like, we're moving, right? We're moving the dial. So
Awesome.
No, appreciate you both.
Okay, great. Thanks.
Thank you.
So let's talk reishi. Reishi is a natural mushroom, completely legal, does not cause any type of alteration in your thoughts. And reishi is an anti-inflammatory. It's really, really great for symptoms of anxiety. If you also have high blood pressure, reishi is something really, really good that helps with blood pressure. We recommend this for people who are really needing to have additional focus. If you have sleep issues, anxiety issues, or blood pressure issues, check out reishi.